Hi, everyone. This is Sam Collins of H.J. Ross, the coding and billing expert for chiropractic. And I'm thanking you for spending a little time with me, but let's get right to it. Let's talk about what's going on with personal injury. How do I diagnose this properly? How do I make sure I'm getting my claims paid? In my dad's practice, I was with him some 20 years, and we focused primarily on personal injury. And I learned quite a few tidbits from my dad on making sure my claims could get paid. So personal injury is probably the last place you're going to have with full pay, no reductions, not a lot of PPO things go on. However, insurance companies do things to potentially cause you to not get paid. So let's kind of highlight that, and let's go through some slides. So have a look here. Just personal injury diagnosis. Note my email because I'm going to offer you something you can get from email coming up. But the bottom line is for personal injury, it's diagnosis. Diagnosis is the major determining factor that a carer uses for the accepted allowance of care. In other words, the more severe the condition, the more care you get. The more simple the condition, the less care. Certainly makes a lot of sense. So do make sure, am I using the right codes to designate the level of care that I'm providing? So by example, think of it this way. Are you diagnosing like a Monet or a Rembrandt? The picture on the left is a Monet, though very pretty painting, is not very specific. In fact, I have no idea who that is. That could be anyone in the royal family, maybe even Meghan Markle. On the right side, of course, is a Rembrandt type or a portrait. I want you to think along the lines, is my diagnosis really giving a complete picture? For instance, neck pain is absolutely accurate, but is that really a diagnosis we'd want to use for personal injury? No, we'd want to certainly have a sprain or a strain. That's very specific. So always think, try to diagnose in a way that's going to give you a more accurate picture, or if you will, a Rembrandt. Personal injury must have trauma. And this is one of the biggest issues doctors run into, because often you've heard from attorneys and others, don't use trauma because they're going to limit the amount of care. Frankly, there has to be trauma as part of the diagnosis. It was a trauma case. The lack of trauma will cause potentially a denial, which means you do need to have cervical sprain strains or lumbar sprains. There must be an S diagnosis. Now, why do I make this such an emphasis? Well, take a look at this. Here's a denial from an insurance, and note what they say. The diagnosis reported by the provider may represent a condition occurring as a result of a motor vehicle accident or an unrelated condition. The insurer may request additional documentation from the provider because the relatedness is not clear. This doctor coded simply headaches and neck pain. As a consequence, could a person have headaches and neck pain not related to an accident? And that's really the issue. You must make sure you're indicating trauma. Now, the problem is people worry that trauma is only going to give you a limited number of visits. Well, certainly a sprain strain, by all intents and purposes, should probably get better in 6 or 8 weeks, even without care to some extent. So therefore, what is it about the severity? What is it about other complicating factors? And I think this is where we have a problem. Remember, there are complications. There's more than just sprain and strain. When they affect recovery, make sure they're included, at least part of the chart notes. By example, I note here, symptoms that have been greater than 8 days often will increase the need for care 1.5 times. Well, that's certainly not a diagnosis, but certainly that's something we want to highlight in the chart notes. A person has waited a week to come in, or maybe the patient's had many more accidents. But here's the third one, an anomaly or structural pathology. Think of most of your patients that have been involved in a pretty significant car accident, whiplash type injury. Does their neck start to show some type of kyphosis or reversal? I would say almost always. So this type of anomaly or structural pathology is going to increase care by 2 times. Anything superimposed, even notice here, is going to be 2 times. So make sure you're coding kyphosis. If you do not diagnose it, it is not there. Think of how many times you code just a whiplash, and they're assuming it's just a whiplash. But if there is spondylosis or certainly reversal of curvature, it is definitely going to make a difference. So medical necessity is determined by diagnosis, and there can be more than one diagnosis. But be careful, do not just do redundant things. Do not code what's inherent to the primary. So one of the problems I see doctors do is they'll code sprain strain and include pain. Well, sprain strain is inherent with pain, so pain is not helping you with your coding. However, added codes can broaden and define what's going on. Think of how many times, again, a patient will have a pretty significant whiplash, reversal of curvature, muscle spasm. Muscle spasm is not inherent to a sprain strain. Therefore, when there's significant muscle spasm, it should be indicated. That gives the reason for doing the tissue work you do. So make sure we're adding everything to it. By example, though, muscle spasm can only be used once. The code for muscle spasm is M62830, and that's muscle spasm of the back specifically. So even when there are multiple regions of the back, the code on the claim form can only be used once. The chart notes is where you will indicate multiple areas, such as lumbar spine, thoracic spine, but again, only use it once. But that's a significant diagnosis to give a better picture. Think of it, if you described a human being just as that, a human being, that would be accurate. But that would not be the best way to describe to see any differences. Give me some specifics. Is it male or female? What's height and weight, and so forth. Another problem we run into is people think that using causation codes are necessary. They're not required. In fact, I have a little meme here that's sort of funny. It says, I'm not always required to work on a Saturday, but when I do, I code Z56.3 for a stressful work schedule. That is literally a diagnosis. Now, does that help you? No. For instance, look at this first one, V43.51XA. It's the car driver injured in a collision with a sport utility vehicle. Well, great. Guess what the auto insurance already knows? It was a car accident. This is not helpful. What's helpful is code what is wrong with your patient. Code the trauma, code the things that occurred, not that there was a car accident. You could have a car accident with no injury. So code the injury. So let's go through what are trauma codes. So take a look what I've done here, and this list will be available to you via email, just sent to me. You're going to notice I start just within the head. We have codes for headaches. Don't code a headache R51 after a car accident. I would assume it's probably post-traumatic. Notice there's an unspecified post-traumatic headache, but then you could even go with acute or chronic. Every time a person's been in a car accident and they have a headache, I would assume it's probably post-traumatic. Therefore, make it a reason to show that the accident caused it. I've seen an office denied for headaches because they simply coded headaches. The insurance company then looked at the patient's charts from the past and noted they had headaches prior. Therefore, they're saying maybe it's part of the prior problem. So this way we're demonstrating it's definitely part of the accident. Notice also things like concussion, post-concussion syndrome. Notice the codes for sprain, strain, even of the jaw. Now let's get to cervical spine. Notice I put the sprain strain codes. Now here I put S134XXA, that's the sprain. And again, that's going to be of upper cervical. I'm not sure most people are aware that S134XXA is upper cervical. Whiplash. The S138XXA is for other parts. So technically, potentially, if you're trying to describe a pretty severe injury to the neck, you want to use both codes to demonstrate the upper and lower. Now you're going to notice I put also with it the S code to indicate sequelae. And so there's often a lot of confusion about this sequelae, or do I use A, D, or S? But before I go there, just highlight just a few other things here. Notice injury to nerve root. So if someone's had a radiculitis post-accident, would you code just radiculitis, or is there going to be an injury? Notice again, try to make sure we're demonstrating, was this part of the injury? And notice these codes end in the A, D, or S as well. So let's deal with that. When do I use the A? The placeholder characters I think are confusing, and this is where people run into problems. You'll notice I put all three here, the A, the D, and S, and it says initial encounter, subsequent encounter, and sequelae. And certainly, if you look at it just that way, it would appear that the initial encounter is the first visit, and subsequent encounter would be the follow-up. And actually, that's exactly wrong. Take a look here of what initial encounter really means. And notice this is from the 2019 code book, specifically page 20. The term initial encounter is somewhat misleading, as it actually refers to the period of time when the patient is receiving active treatment for the condition. It is the encounter where the patient is receiving active treatment. Well, think of it. What type of care does a chiropractor give? Active. You're treating. Therefore, during the whole course of care, it's likely to be the A. The reason you almost never use the D, this is the encounter after the patient has completed active treatment. So in other words, this would be, for instance, the final visit if the patient was completely asymptomatic. And I would suggest probably not to ever use that code because it doesn't equal treatment. Now, sequelae may be used. Sequelae certainly to me indicates kind of a prognosis of this patient. We all know that patients often have residual symptoms as related to a car accident. So notice here, sequelae or complications or residuals, and notice how we've coded it. The A diagnosis is myalgia of the accessory muscles of the neck, and S134XXS equals sequelae. What are we saying? This patient has ongoing myalgia as a residual effect of the accident, maybe beyond the natural healing time, maybe after 3 months, this patient's still experiencing it. That would be a reason to use it. But as far as when you're doing active care, always use the A. So here's a continuation. Notice all these codes for the cervical spine from disc degeneration otherwise. Certainly these aren't caused by an accident, but they certainly will be a secondary factor to create a longer need for care, a complication of recovery. But I'm going to highlight, I talked about that kyphosis. Notice the codes M4012, M4013, other secondary kyphosis. What is other secondary? Secondary to the car accident. If you get significant muscle spasm, if nothing else, to the cervical spine, you're going to cause a straightening of the lordotic curve. As a consequence, the body will not heal as fast and probably is going to take 1.5 to 2 times longer to get better. Here's the problem. If you code only whiplash, they're assuming it's just a strained sprain. Unless you code these other factors, they don't exist. Notice for thoracic spine, we've done the same thing. The sprains and strains, the muscles, the injury to nerve root, radiculopathy, all these factors are part of an accident. Just make sure trauma is part of it, and then give me all the things that are going along with it. Again, I go back to the Rembrandt. Paint a picture that gives a complete issue of this patient so that it warrants the level of care you're attempting to provide. Notice continuing on here, we have codes for lumbosacral spine, same format, the sprains, the strains. Notice we have sprain of lumbar and then other parts. Other parts is going to equal lumbosacral. Then notice also, though, these codes for injury to the plexus, injury to the sciatic nerve. If someone has significant sciatica after a car accident where there's a sprain strain, I don't think I'm just going to code sciatica. I'm actually going to code the injury because that was the causation. And then notice, of course, all the codes for the other types of issues that can be along with it, radiculopathy and so forth, so long as trauma is part. And that's the big emphasis. Use your trauma codes to indicate that it was caused by the accident. There's a few more miscellaneous codes. Notice the amount of codes here. We have acute pain due to trauma, chronic pain due to trauma. Well, let's take a look at this chronic pain due to trauma. A patient is having residual pain months after an accident. Well, G8921 could be the sequelae of that accident. Many patients will often experience continued pain, certainly managed by chiropractic, but goes beyond the normal. One of the reasons, though, and I'm going to really highlight this specific code, M2428, disorder of ligament, which essentially equals ligament laxity. If you ever do a flexion extension x-ray of a patient that's had a pretty significant whiplash, you will almost always find translation or ligament laxity, and hence why patients often have lots of residual problems, but it's not diagnosed because they didn't have the proper images to determine it. So I'm going to suggest any significant trauma, flexion extension becomes a must, particularly for patients with ongoing symptoms beyond the normal etiology. Notice also here, though, other codes for muscle spasm, myalgia. Remember, the myalgia code was deleted. M79.1 was the old. It's M79.11, which was the first one. That's for the neck. But then notice I have this code M79.18. What if a person is having residual or ongoing myalgia as a result of an accident to the lumbar spine? Well, the M79.18 would fit to that. And then I notice I threw in some other codes here just for contusion. My issue for you is going to be make sure that you're diagnosing trauma. An insurance company's job, frankly, in many ways, my opinion now, is to try to not pay a claim or not to pay too much. Our job is to make sure, are we giving the accurate codes that describe what's really going on with the patient to give the amount of visits necessary? I'm not saying more visits. I'm saying, are we getting the accurate number of visits in order to treat this patient? There must be trauma as part of it because trauma was the injury. Now, I've given you a list here of about 300 codes. You're welcome to think of along the lines of trauma related and get the list, but simply just email me. My email is sam@hjrossnetwork.com. Simply send me an email and include in the email, Sam, I would like the personal injury diagnosis list. I'll send you over the list that I've just shown, because what I want to make sure is that a chiropractor is doing the best job we can of making sure we've got the diagnosis that relates to the condition we're treating and allows us to treat with the length of care and the necessity of care, not too much, but the right amount. I often think we're not getting the right amount because we're giving too simplistic of a code. Thank you. And next week's host will be Dr. Jerry Klum. So come back next week. And again, I thank you for some time, and I'll see you on the next one. Thanks so much.